Hello, everyone. Welcome to our lecture on coronary artery disease and acute coronary syndrome, which is part of our perfusion module in HCC2. So coronary artery disease, or CAD, is one of the leading causes of death worldwide. It affects millions of people every year. So understanding coronary artery disease and its progression to acute coronary syndrome is essential for nurses because early recognition and prompt intervention can mean all the difference between life and death. So throughout this lecture, we're going to break down the pathophysiology, the risk factors, clinical manifestations, diagnostic tools, and management strategies for both coronary artery disease and acute coronary syndrome. We'll also discuss that crucial role that nurses play in assessing patients, administering treatments, and providing education to prevent any complications. So by the end of this presentation, you should feel very confident in identifying at-risk patients, recognizing early signs of myocardial ischemia, and applying evidence-based interventions to improve patient outcomes. So let's get started. So coronary artery disease includes both chronic stable angina and acute coronary syndromes, and it affects the arteries that supply oxygen-rich blood and nutrients to the heart muscle. When these arteries become narrowed or blocked, then blood flow to the myocardium is restricted, and this can lead to ischemia, where the heart muscle doesn't receive enough oxygen to meet its demands. If ischemia is prolonged and severe, it can progress to an infarction or cell death, which causes irreversible damage to the heart tissue. One of the main causes of coronary artery disease is atherosclerosis, which is a condition where fatty deposits build up inside the arteries, causing them to harden and narrow over time. This process is usually triggered by damage to the endothelial lining of the blood vessels due to things like smoking, high cholesterol, high blood pressure, diabetes, and inflammation. As these fatty deposits accumulate, they form plaques that restrict blood flow. If a plaque ruptures, it can lead to the formation of a thrombus or a clot, which can further narrow or completely block the artery. At this stage, we call it a complicated lesion. Fortunately, the body has a backup plan, so over time, it can develop what's called collateral circulation, meaning new blood vessels form around the blocked artery to maintain some level of perfusion. However, this process takes time, so in cases of sudden or severe blockage, the heart may not have enough time to compensate, which leads to life-threatening consequences. While the overall death rate from coronary artery disease has declined in recent years due to advances in treatment and greater awareness of risk factors, coronary artery disease still remains a very serious health problem. And this is why early recognition and prevention are so important to manage coronary artery disease and reduce its impact. All right, so now that we've introduced coronary artery disease, let's take a closer look at how it progresses and the major coronary arteries that are involved. So on the left side of the screen, you see a flowchart that illustrates the two primary pathways of CAD, which is chronic stable angina and acute coronary syndrome. So chronic stable angina is predictable chest pain. It occurs with exertion, and it's typically relieved by rest or nitroglycerin. And it happens because of narrowed coronary arteries that still allow some blood flow, but it's not enough to meet the increased oxygen demand of the heart. If coronary artery disease worsens, then we start to get into acute coronary syndrome. And this is an umbrella term that includes both unstable angina, non-ST segment elevation myocardial infarction, which is a non-STEMI or NSTEMI, and then we have an ST segment elevation myocardial infarction known as a STEMI. So we're going to go over each of these individually so you get a better idea of what is involved with each one of these. And that's going to be on the next few slides. But if looking on the right side of the slide, you see a diagram of the major coronary arteries. So these arteries branch off from the aorta and they supply oxygenated blood to the heart muscle. The left main coronary artery quickly divides into the left anterior descending or LAD artery and into the circumflex artery, both of which supply the left side of the heart. The right coronary artery, or RCA, supplies the right side of the heart, and it also plays a big role in supplying the electrical conduction system. So the location of a blockage within these arteries determines the severity and the type of myocardial infarction that a patient may experience. So now let's talk about chronic stable angina. So this is a type of chest pain that occurs with moderate to prolonged exertion, and it follows a pretty predictable pattern. Chronic stable angina is caused by a fixed atherosclerotic plaque in the coronary arteries, which limits blood flow to the heart muscle. Because this plaque is stable, the patient experiences chest pain or angina whenever the heart works harder, such as during exercise or when they're stressed. But the pain does not typically change in its frequency, its duration, or its intensity over time. So some of the key characteristics of chronic stable angina, the pain, again, is going to be consistent with previous episodes, meaning that patients will recognize the symptoms and they usually know what triggers them. The discomfort or the chest pain that the patient has is typically going to be relieved by resting or through the use of nitroglycerin, which works by dilating blood vessels and improving the blood flow to the heart. Usually, chronic stable angina is managed with medications like beta blockers, calcium channel blockers, or long-acting nitrates to reduce that oxygen demand and improve blood supply to the heart. So unlike acute coronary syndrome, chronic stable angina is not considered a medical emergency. However, it does indicate that there is underlying coronary artery disease, and if it's left unmanaged, then it can progress to more severe forms, such as unstable angina or even a heart attack. All right, so now let's discuss acute coronary syndrome, which represents a spectrum of conditions that are caused by the sudden reduction of blood flow to the heart muscle. Acute coronary syndrome includes unstable angina and an acute myocardial infarction, which can either be an ST segment elevation myocardial infarction, which is known as a STEMI, or a non-ST segment elevation myocardial infarction known as an NSTEMI or non-STEMI. So the underlying cause of acute coronary syndrome is usually the rupture of an atherosclerotic plaque in the coronary arteries. Whenever a plaque ruptures, it triggers a cascade of events. We see platelet aggregation or clumping at the site of the rupture. Then we see thrombus or clot formation, which can partially or even completely block blood flow. And we also see vasoconstriction or narrowing of the blood vessel, which can further reduce oxygen supply to the myocardium. So the severity of the coronary artery obstruction determines the specific disease process. If the blockage is partial, then it causes an unstable angina or a non-STEMI, meaning that there is ischemia, but not full thickness heart muscle damage. If the blockage is complete, it results in a STEMI. And again, we're going to go over these individually, so don't worry if it's getting over your head at the moment. So when we have a blockage that's complete, again, that's a STEMI, and this leads to full thickness myocardial infarction, and it requires immediate intervention. Once a coronary artery becomes 50% or more occluded, blood flow is significantly impaired, and it leads to myocardial ischemia during increased demand. So for example, during physical activity or emotional distress. If the blood flow is not restored quickly, ischemia progresses to infarction, which causes irreversible heart muscle damage. All right, so let's talk about unstable angina. This is a more serious and unpredictable form of angina as compared to chronic stable angina. Again, it's going to be classified under acute coronary syndrome, and it serves as a warning sign of a potential myocardial infarction or heart attack. So unlike stable angina, where the chest pain occurs predictably with exertion, unstable angina can occur at rest or with minimal exertion, and it causes significant activity limitation. So patients will usually report an increase in the frequency, duration, and intensity of the chest pain episode, with discomfort lasting longer than 15 minutes, and it being poorly relieved by rest or nitroglycerin. So again, those are your differences between unstable angina and chronic stable angina. From a diagnostic standpoint, ST segment changes may be present on a 12-lead ECG, which indicates that there is myocardial ischemia occurring. And then troponin levels may remain normal, as ischemia is present, but it doesn't cause any detectable myocardial damage or cell death. And again, troponin is a cardiac enzyme that becomes elevated over time when there is some sort of myocardial damage. Or ischemia that causes damage. So the troponin levels remaining normal is a key differentiator from a myocardial infarction, where troponin levels are elevated, again, due to that heart muscle injury. So unstable angina includes several subtypes. We have new onset angina, which is chest pain that occurs for the first time. Typically that's triggered by exertion or just that increased cardiac demand. We also have vasospastic angina, which is also known as Prinzmetal's angina. And this is chest pain that results from a coronary artery spasm, which can occur even at rest. We also have pre-infarction angina, which is chest pain that develops in the days or the weeks that lead up to a myocardial infarction, and it signals worsening cardiac instability. So again, unstable angina does not cause any permanent myocardial damage, but it does require immediate medical evaluation and intervention because it significantly increases the risk of progressing to a full myocardial infarction. All right, so now let's discuss the most serious form of acute coronary syndrome, which is a myocardial infarction or MI. A myocardial infarction, which is commonly known as a heart attack, occurs when myocardial tissue is abruptly and severely deprived of oxygen due to a significant reduction or a complete blockage of coronary blood flow. So if blood flow is reduced by 80 to 90%, then ischemia develops rapidly. And without prompt intervention, the ischemia can progress to myocardial injury and necrosis, which causes permanent heart muscle damage. So we have two primary types of a myocardial infarction. We have an NSTEMI, which is a non-ST segment elevation myocardial infarction, and we have a STEMI, which is a ST elevation myocardial infarction. So a non-STEMI or NSTEMI is characterized by ST segment depression and T-wave inversion on a 12-lead ECG, again indicating that there is myocardial ischemia occurring. With a non-STEMI, we're going to see elevated cardiac troponin levels, which confirm that myocardial cell death. Now this is what separates it from unstable angina. Remember, in unstable angina, the troponin levels remain the same, or they remain non-elevated. Here in our NSTEMI, we do have elevation of our cardiac troponin levels. A NSTEMI occurs because there is a partial occlusion of a coronary artery, meaning that some blood flow is still reaching the heart. Causes can include things like coronary artery narrowing, vasospasm, or even sluggish blood flow, which leads to ischemia. Now, a STEMI, on the other hand, is a much more severe myocardial infarction, and it's considered a medical emergency. This is characterized by having that ST segment elevation in 2 or more contiguous leads on a 12-lead EKG. That's why when we get into our dysrhythmias lecture, we talk about how important it is to look at that ST segment to make sure, because it's supposed to go back to baseline. With a ST segment myocardial infarction, we see elevation of that ST segment. And this is the hallmark sign of infarction and necrosis. With a STEMI, there is complete and abrupt blockage of a coronary artery, usually due to the rupture of an atherosclerotic plaque, platelet aggregation, and a thrombus formation. Because blood flow is entirely cut off, immediate revascularization, either with thrombolytic therapy or a percutaneous coronary intervention, or PCI, is critical to restore perfusion and to limit the extent of heart muscle damage. So whenever an MI occurs, the damage follows a progression. So we first have the outermost area of the heart that's being affected. So this is the zone of ischemia, which is, again, that outermost area where oxygen supply is low, but it's still reversible. The zone of injury consists of tissue that is damaged, but can potentially recover if blood flow is restored quickly. And the zone of necrosis is that innermost area where cell death has occurred, which leads to permanent scarring. So rapid intervention for an MI is essential because time is muscle, and in this case, it's heart muscle. The longer that the heart remains deprived of oxygen, the more extensive the damage. So nurses play a very critical role in recognizing those early signs of a myocardial infarction, initiating those emergency interventions, and educating patients on different prevention strategies. All right, so this picture just gives a really good visual summary of the progression of acute coronary syndrome and the key differences between chronic stable angina, unstable angina, NSTEMI, and a STEMI. So starting on the left, we see stable angina. And again, in this stage, angina occurs due to increased myocardial oxygen demand in the presence of a stable atherosclerotic plaque. The vessel is still able to dilate enough to maintain blood flow, preventing infarction. So again, with stable angina, the ECG is fairly normal. The troponin levels remain normal as well, and this is considered a predictable and manageable condition. Again, typically brought on by stress or physical activity and is relieved by nitroglycerin and rest. Unstable angina, so here the plaque ruptures, which leads to thrombus formation and a partial occlusion of the artery. The angina becomes more unpredictable and it may occur at rest or it may worsen rapidly. So with unstable angina, the ECG may show some ST segment depression or T-wave inversion, but it doesn't show any sort of infarction. The troponin levels remain normal, especially since there is ischemia, but there is no myocardial cell death yet. Again, unstable angina is going to be a warning sign of an impending heart attack. An NSTEMI, which is a non-ST segment elevation myocardial infarction. So this is where a plaque ruptures and a thrombus leads to a partial coronary artery occlusion, but now there's enough ischemia to cause infarction, particularly in the subendocardial layer of the myocardium. So with an NSTEMI, the ECG may show some ST depression or even T-wave inversion. And what makes it different from the unstable angina is that the troponin levels are now going to be elevated, which confirms that there is myocardial damage occurring. So again, while NSTEMI doesn't involve full thickness myocardial injury, it still requires urgent intervention to prevent any further damage. A STEMI, or ST segment elevation myocardial infarction, is the most severe form of acute coronary syndrome, and it's caused by a complete occlusion of the coronary artery, which results in transmural or full thickness myocardial infarction. So here with a STEMI on the ECG, we see that ST segment elevation. Again, that's our hallmark sign of a full infarction. Our troponin levels are also going to be elevated. However, I do want to note that when these happen really abruptly, sometimes by the time that the patient gets to the hospital, the troponin level hasn't had quite enough time to elevate. So it is still, if you're working the ER, it's still somewhat normal to see a STEMI occurring and the troponin levels still be within normal range. However, again, because this has happened so abruptly, over time, as we care for the patient in the hospital, the troponin levels will go up, and what we want to see is them trending down, especially after treatment. So again, a STEMI is a medical emergency that requires immediate revascularization, either through thrombolytic therapy or a PCI, to restore that blood flow and to save the heart tissue. So again, key takeaway from this slide is how acute coronary syndrome progresses in its severity from stable angina to a STEMI. Those ECG changes and troponin levels are critical to differentiate these conditions, which helps us provide the appropriate treatment strategies. Now let's take a closer look at the coronary arteries and how their obstruction determines the type and the severity of a myocardial infarction. So the symptoms and complications of an MI largely depend on which coronary artery is affected and the extent of the damage to the ventricular wall. So the left anterior descending, or LAD artery, this supplies blood to the anterior wall of the left ventricle and to the intraventricular septum. So a blockage here leads to an anterior wall MI or a septal MI. Anterior wall myocardial infarctions have the highest mortality rate because they often result in left ventricular failure and very severe dysrhythmias due to that extensive damage to the heart's primary pumping chamber, which is the left ventricle. The circumflex artery supplies blood to the lateral wall of the left ventricle, and it can also perfuse the posterior wall or the SA and AV nodes. So a blockage in this artery can cause a posterior wall MI or a lateral wall MI. And I know you're like, oh my gosh, all these different walls. We are going to talk about it here shortly, so don't panic. The right coronary artery, or RCA, supplies blood to the right ventricle, as well as the inferior wall of the left ventricle and the SA and AV nodes in most people. So a blockage in the right coronary artery often leads to an inferior wall MI. About 50% of inferior wall MIs are associated with right ventricular infarction, which can significantly impact cardiac output and hemodynamic stability. Because the right ventricle is involved, a right-sided EKG is going to be crucial in assessing the extent of the infarction. So key takeaways here: the location of the coronary artery blockage determines the area of infarction and the potential complications. Anterior MIs are the most critical due to the risk of left ventricular failure and arrhythmias, and inferior MIs can be complicated by right ventricular involvement, which requires also additional monitoring with a right-sided ECG. All right, let's get into the etiology and incidence of acute coronary syndrome. So the primary cause of acute coronary syndrome is atherosclerosis, which leads to that narrowing or blockage of the coronary arteries due to plaque buildup. Over time, these plaques can rupture, which, as we've talked about, can trigger clot formation and an acute cardiac event like an MI. So there are risk factors for atherosclerosis. They're divided into two main categories. First, we have modifiable risk factors, which are the lifestyle-related risk factors that can be improved with behavior changes. So modifiable risk factors would be things like smoking, obesity, high blood pressure, tobacco use, diabetes, and high cholesterol. Our non-modifiable risk factors, which are factors that can't be changed, include things like age, gender, race, family history, and genetic predisposition. Another significant risk factor is metabolic syndrome, also called insulin resistance syndrome. So this is diagnosed when a person has at least 3 of the following things: central obesity, high blood pressure, hyperglycemia, high triglycerides, and a low HDL, which is the good cholesterol. Women with abdominal obesity and metabolic syndrome have a particularly high risk for developing coronary artery disease and acute coronary syndrome. Looking at incidence and prevalence, so the average age for a first myocardial infarction is 65 years for men and 72 years for women. Family history plays a pretty big role. It increases the likelihood of developing coronary artery disease. Again, postmenopausal women are at increased risk due to just having decreased estrogen levels, which previously provided some cardiovascular protection for them. So studies out there can also indicate that there are certain ethnic groups that have a higher prevalence of CAD, with non-Hispanic Black males having the highest mortality rates from heart disease. So key takeaways here: some risk factors like age and genetics can't be changed, while those risk factors that are modifiable with lifestyle changes and medical management hopefully can be changed and decrease the likelihood of acute coronary syndrome. So as nurses, we play a pretty big role in educating patients on the importance of those preventative measures, such as smoking cessation, weight management, blood pressure control, and healthy dietary choices. All right, so moving to our health promotion and maintenance for acute coronary syndrome. So preventing ACS and reducing the risk of cardiovascular events requires a proactive approach to lifestyle modification. Many risk factors for coronary artery disease and myocardial infarction, again, are modifiable, like we talked about on the last slide. So early intervention can significantly lower the risk of disease progression. So first, let's talk about emergency preparedness with AEDs. So first, it's important to recognize that sudden cardiac arrest is a common consequence of acute coronary syndrome. 90% of cardiac arrest victims die before reaching the hospital, often due to ventricular fibrillation, or VFib. Because of this, automated external defibrillators, or AEDs, are placed in public places like shopping centers, airports, workplaces, and gyms. Many high-risk patients may also have a personal AED at home or at work, and knowing how to recognize cardiac arrest and use the AED can save lives. So first, let's talk about modifying risk factors, which is the key to prevention. First is smoking cessation. So smoking is one of the most significant risk factors for coronary artery disease. So educating patients on smoking cessation programs, nicotine replacement therapy, and behavioral support is so important. If a patient smokes, we want to encourage them to quit. If they don't smoke, then we want to encourage them not to start smoking. Patients need to consume sufficient calories. So we're talking about dietary modifications. They need to get enough calories to meet their body's demands while avoiding any excess fats, sodium, and cholesterol. We want to limit our cholesterol intake to less than 200 milligrams per day and reduce sodium intake to under 1,500 milligrams per day, if possible. We also want them to have regular lipid level checks, and statin therapy may be required for patients who have high cholesterol. With physical activity, so exercise is going to improve cardiac function and reduces risk factors like obesity, high blood pressure, and diabetes. Patients need to aim for at least 40 minutes of moderate exercise 3 to 4 times a week. And if structured exercise isn't possible, then maybe we want to encourage something like daily walking for at least 30 minutes or just some sort of alternative movement strategy like taking the stairs instead of the elevator. Also, we want to go over managing diabetes and high blood pressure. So again, diabetes increases the risk of acute coronary syndrome because it promotes vascular inflammation and atherosclerosis. So it's critical that patients work very closely with their healthcare providers to manage their glucose levels. High blood pressure is another major contributor to cardiovascular disease. So patients need to monitor their blood pressure regularly and follow their healthcare provider's advice if readings are consistently elevated. Abdominal obesity, again, is a major risk factor for acute coronary syndrome. So patients need to focus on reducing their saturated fats, sweets, and cholesterol-rich foods while they increase physical activity. All right, so now let's get into our nursing assessment for acute coronary syndrome. So recognizing those early signs is important for timely intervention and improved patient outcomes. So a comprehensive assessment includes a history, a physical exam, and a psychosocial evaluation to identify any key risk factors and symptoms. So starting with our patient history. So first and foremost, if a patient is actively experiencing symptoms of acute coronary syndrome, then we want to prioritize our interventions first and delay the history collection until the patient is stable. Whenever it's possible, we need to gather family history and modifiable risk factors, including smoking, diet, alcohol use, physical activity, and their BMI. With our physical assessment, we need to recognize the signs of acute coronary syndrome. So rapid assessment is so important. Chest pain is the primary symptom, but not all patients experience chest pain in the same way. So we need to evaluate the pain characteristics by assessing the onset, location, radiation, intensity, duration, and precipitating and relieving factors of the chest pain. And we're going to use a pain scale to quantify the severity. Sometimes we have atypical presentations, and these are more common in women and older adults and even diabetic patients. So these symptoms may include things like indigestion, pain between the shoulders, jaw discomfort, a choking sensation, and unusual fatigue. I've actually seen patients come in with a full-blown STEMI, and one little lady was just complaining of upper abdominal pain, which was more kind of an indigestion feeling for her. And again, that was an atypical presentation, and she was having a STEMI. I've also had an older lady come in who was just complaining of having increased fatigue. We did an ECG, and she was also having a STEMI. So again, those atypical presentations are still out there. Again, they're going to be more common in women and older adults and your diabetics. But just because someone isn't solely complaining of chest pain does not mean that they're not having an acute coronary syndrome issue. Other associated symptoms that patients may have along with their chest pain are nausea, vomiting, diaphoresis, which is that excessive sweating, dizziness, weakness, palpitations, and shortness of breath. So when we're assessing these patients with acute coronary syndrome or that we suspect to have acute coronary syndrome, vital sign assessment is very important. So blood pressure, heart rate, and cardiac rhythm need to be closely monitored. Sinus tachycardia with PVCs is very common after a patient's had an MI. Typically, whenever a patient comes in complaining of chest pain, we have about we have 10 minutes from the time that they come to the door to get an EKG done on them so that we can get the intervention started for a heart attack or myocardial infarction, or so that we can treat the patient appropriately. Also, we're going to assess those distal peripheral pulses and the skin temperature. Cool, clammy skin and diminished pulses can indicate poor cardiac output. Our respiratory status needs to be evaluated, so crackles or wheezing could indicate that the patient has left-sided heart failure. A fever may be present in the days that follow an MI, just simply due to the inflammation from the myocardial necrosis. Getting into our psychosocial assessment. So patients experiencing acute coronary syndrome often display denial, anger, or sometimes even depression. Denial is a very common early reaction, leading to delayed medical attention. Patients may rationalize their symptoms, like, oh, it's not my heart, I just have indigestion, or I just, I exerted myself too hard. So that denial delays medical attention and can be detrimental for patients. Fear, anxiety, and depression can also complicate recovery, so assessing and addressing these emotions is very important. All right, continuing with our assessment here of acute coronary syndrome. So once we identify the potential signs and symptoms of ACS, then we rely on our diagnostics to confirm a myocardial infarction, to assess the severity of the ischemia, and to determine the appropriate treatment strategies. So with our laboratory assessment, we look at those cardiac biomarkers. And again, the most specific and reliable test for detecting myocardial infarction is the measurement of a troponin, whether it be a troponin T or a troponin I. So these troponins are proteins that are released whenever myocardial cells undergo necrosis. These biomarkers rise quickly following an infarction, and they remain elevated for several days. So with someone who's coming in for acute coronary syndrome, typically we're going to do serial troponin testing over several hours to confirm or rule out an MI. An imaging assessment, so a chest x-ray may be performed to rule out other causes of chest pain, such as an aortic dissection or pulmonary conditions. We have thallium scans, we can use cardiovascular magnetic resonance or CMR, echocardiography, and a CT coronary angiography or CTCA can all be used to help identify or visualize areas of ischemia or infarction. However, the electrocardiogram, or ECG, or EKG, is the cornerstone of a diagnosis for acute coronary syndrome. So again, a 12-lead ECG needs to be obtained within 10 minutes of a patient presenting with chest discomfort. The ECG helps determine if an MI is occurring, and it also tells us the location and the severity of the ischemia or the infarction. So again, those ECG key changes that are seen in ACS. So we see with an N-STEMI, we can see ST depression or T-wave inversion, which means we've got some ischemia. And then with an ST elevation, we see this with a STEMI. And again, we see that elevation of the ST segment in 2 or more contiguous leads. This is the hallmark sign of a STEMI, and it indicates that we've got a full thickness myocardial infarction. Some additional diagnostic testing. So physicians may have patients perform an exercise tolerance test or a stress test, and this is used to assess for any exercise-induced ischemia whenever the patient is stable. We can do a cardiac catheterization or angiography, and this is a definitive test for identifying the extent of coronary artery blockage. So typically if someone comes in with acute coronary syndrome, they're going to get a cardiac catheterization at some point during their hospital stay. Someone who's having a STEMI is going to go pretty much directly to the cath lab to go look to see where the coronary artery blockage is and to hopefully fix it with percutaneous coronary intervention or even a coronary artery bypass. Patients that are having an N-STEMI may not go to cath lab until 12 to 24 hours after they present, because again, they're just having a partial occlusion. Doesn't mean it's not urgent, but it's not as emergent as a STEMI. And then patients who have unstable angina will likely go for a cardiac cath as well. Again, it's just not as emergently put on the cardiac cath lab schedule as a STEMI would be. All right, so I want to preface this slide and the information that I give on this slide um, with saying that I don't expect you guys to memorize the stuff on this slide. However, if you're wanting to get into cardiology or even working in the ER, this is something that you're probably going to want to know because it's going to help you be able to take care of your patients a lot better. So y'all have heard me talk about, leads and where the ST segment changes are on the ECG. We're going to kind of hopefully explain that as far as where the STEMI is or where the issue, the ischemia is occurring in the coronary artery and how it correlates over to what we see on the ECG. So ECG changes, again, help determine that location of a myocardial infarction so that we can have a guide for our emergency interventions. So again, a 12-lead ECG, which we talk about on the dysrhythmias PowerPoint, acts as an internal camera. So the 12-lead ECG captures the electrical activity of the heart from 12 different angles. These different views allow us to pinpoint which region of the heart is being affected and which coronary artery is involved in the infarction. So myocardial infarctions most commonly affect the left ventricle, and they're classified by the location of damage. So if you look at this slide here, you can see we've got the heart on the left-hand side of the screen, and it tells you the different leads where you're going to see an infarction occurring on the 12-lead ECG. So an anterior wall MI, which is blockage in the left anterior descending artery or LAD artery. We can also have an inferior wall MI, which is blockage in the right coronary artery. A lateral wall MI is a blockage in the left circumflex artery, and a septal MI involves the septal branches of the left anterior descending artery. And then a posterior wall MI may result from the right coronary artery or the left circumflex artery occlusion. So let's talk about how we can identify a STEMI on an ECG. So a STEMI, or ST elevation myocardial infarction, again, is characterized by ST segment elevation in 2 or more contiguous leads, which again indicates that we've got a full thickness myocardial injury going on. So let's break down these lead groupings here and their corresponding infarct locations. So if we have an anterior MI, which is again that left anterior descending artery occlusion, we're going to see this evidenced in leads V1 through V4. An inferior wall MI, which is due to a right coronary artery occlusion, we're going to see ST elevation in leads 2, 3, and AVF. With a lateral wall MI, which is a left circumflex occlusion, we see an ST elevation in leads 1, AVL, V5, and V6. With a septal wall MI, we see ST elevation in leads V1 and V2, and that's typically characteristic of a left anterior descending artery occlusion. And lastly, a posterior MI. With this, we want to look for ST depression in V1 through V4, and may require posterior leads such as V7 through V9. Again, typically not what we see on our regular ECG. So let's talk about some of the special considerations here. So a right ventricular infarction. If a inferior wall MI is suspected, then a right-sided ECG needs to be performed. And we do this by placing the V leads on the right side of the chest instead of on the left. This helps to determine if the right ventricle is affected, which requires very different management. So right ventricular MIs are preload dependent, meaning that nitroglycerin is going to be contraindicated because it can cause severe hypotension and cardiovascular collapse. Okay, so now that we understand how to assess and diagnose acute coronary syndrome, let's talk about those key nursing interventions that help guide our patient care. So with coronary artery disease, patients may present with either stable angina or acute coronary syndrome. If we are suspecting acute coronary syndrome, then the patient is typically admitted to a telemetry unit for continuous cardiac monitoring or to an ICU if they are hemodynamically unstable. So our priority nursing problems for acute coronary syndrome. focus on reducing myocardial oxygen demand, improving perfusion, preventing complications, and supporting cardiac function. So our priority nursing problems, the first one is acute pain. And this is due to that imbalance between myocardial oxygen supply and demand. And our intervention here is obviously to manage that acute pain. Our second priority is second problem is decreased myocardial tissue perfusion, which is due to that interruption of blood flow. So our interventions are focused at increasing that myocardial tissue perfusion. Our third nursing problem is the potential for dysrhythmias due to ischemia and ventricular irritability. So for this, we're going to first identify and manage dysrhythmias. And our last priority problem is the potential for heart failure due to left ventricular dysfunction. And our intervention here is to monitor for and manage heart failure. Now we're going to go over all of these priority problems in depth, as well as what these interventions actually entail. All right, so effective pain management in ACS is very important to reduce that myocardial oxygen demand and improve cardiac perfusion. So the patient is having pain because they've got ischemia occurring. So when the patient experiences chest pain, we need to act very quickly and efficiently to relieve that discomfort and prevent any further ischemia. So let's talk about the key steps in managing acute pain. First, we're going to evaluate and monitor the patient. So we'll assess pain by using a pain scale, noting the pain's onset, the location, and its intensity. We're going to get vital signs, including blood pressure, heart rate, and an oxygen saturation. We're also going to ensure IV access in case we need to give some medications rapidly. And also, we're going to notify the healthcare provider of the patient status and whether or not they have any changes. So now let's talk about drug therapy for pain management. So nitroglycerin is first-line treatment. So nitroglycerin vasodilates the coronary arteries. It makes them bigger, so this improves blood flow to those ischemic areas. Nitroglycerin also reduces the preload and the afterload, so that lowers the myocardial oxygen demand. So a sublingual nitroglycerin is given 1 dose every 5 minutes, up to a max of 3 doses. If chest pain is persisting after 3 doses, then we really need to be suspecting an MI. Typically, what we're educating patients if they're out in the field, if they take one nitroglycerin and they're still having chest pain, we want to tell them to go ahead and contact 911 and come to the hospital. IV nitroglycerin may be started for persistent ischemic pain as well. However, with nitroglycerin, it's very important to note that it has a big side effect of a headache. And this is typically going to be treated with acetaminophen. So it's always really nice to warn patients who are taking nitroglycerin that, hey, this medication is probably going to give you a headache, and we can treat it with acetaminophen if you need it. Our next drug that we can use is morphine sulfate, or just morphine. And this is for pain that's unresponsive to nitroglycerin. And morphine works because it decreases pain, as well as the myocardial oxygen demand, and it decreases the cardiac workload. Morphine relaxes smooth muscle, and it reduces catecholamine release, which is a stress response. However, with morphine, we want to monitor for hypotension, respiratory depression, bradycardia, and nausea. Again, morphine sulfate does still reduce preload, and so that's why it's very important to monitor the blood pressure whenever we're giving morphine. Next, we have oxygen therapy. So we want to administer oxygen only if hypoxemia is present. So our goal is to maintain an SpO2 greater than 90% using 2 to 4 liters per minute via nasal cannula. Some additional nursing interventions. We want to place the patient in a semi-Fowler's position for comfort and for oxygenation. Provide a calm and reassuring environment to reduce their anxiety. This is already a very stressful situation. And we want to encourage slow, deep breaths to improve that oxygen delivery and relaxation. All right, so now that we've talked about how we can manage acute pain and what medications we do for that, now let's talk about how we can increase myocardial perfusion. Because again, that's our goal. We want to restore blood flow to the heart as quickly and as efficiently as possible. And that's where drug therapy really plays a big role. So we're going to go over some of the different key medications and how they can help improve patient outcomes. So first and foremost is aspirin. So this is a staple in ACS management. It inhibits platelet aggregation and vasoconstriction, which prevents clot formation. If a patient presents with acute chest pain, they need to chew 4 baby aspirins, each is 81 milligrams, for a total dose of 325 milligrams. This helps to quickly reduce clot formation. For long-term prevention, though, patients with coronary artery disease need to take a daily, low-dose, non-enteric coated aspirin. In addition to aspirin, we also oftentimes will add a P2Y12 inhibitor like clopidogrel, also known as Plavix. And this medication works by preventing platelets from clumping together too. It also further reduces the risk of clot formation because it prevents these platelets from clumping together. These medications are commonly used for up to 12 months following an acute coronary event, and especially after a stent is placed. So now for anticoagulants. So antiplatelets prevent platelets from sticking together, but anticoagulants actually go a step further by preventing clot formation altogether. So anticoagulants be things like heparin and Lovenox. These drugs are crucial in acute coronary syndrome management to reduce the risk of thrombus expansion and further arterial occlusion. Beta blockers or beta adrenergic blockers. So this is a class of drug that can significantly improve the survival rates in acute coronary syndrome patients. So these are your OLAL medications, medications like metoprolol and carvedilol. These are beta blockers, and they help by reducing the infarct size. They can prevent ventricular dysrhythmias, and they can decrease mortality. So beta blockers slow the heart rate, and they decrease contractility, which allows the heart to work more efficiently. However, it's important to always monitor for bradycardia, hypotension, and respiratory symptoms, especially in patients who have a history of asthma or COPD. ACE inhibitors or ARBs. So to prevent long-term complications, usually we start patients on an angiotensin-converting enzyme inhibitor or an ACE inhibitor. And these are your pril medications, like lisinopril, captopril, enalapril, all of those. If a patient doesn't tolerate an ACE inhibitor, such as they develop that angioedema, which is the swelling of the mouth and lips, which is very common to medications like lisinopril, or maybe they have a dry cough that comes with ACE inhibitors, then we'll place patients on an angiotensin receptor blocker known as an ARB. And these are your sartan drugs, like valsartan and losartan. And usually we put patients on ACE inhibitors or ARBs within 24 hours of their cardiac event. These medications reduce blood pressure and they reduce the workload on the heart. However, we need to closely monitor potassium levels, urine output, and we need to watch for hypotension or, again, that persistent dry cough, all of which are very common to those ACE inhibitors. Next, we have calcium channel blockers. So for patients with vasospastic angina or persistent hypertension despite beta blocker therapy, then calcium channel blockers, and again, these are your pene medications or medications that end in pine or pene. So calcium channel blockers like imlodipine or nifedipine may be prescribed. So these medications, calcium channel blockers, promote vasodilation and myocardial perfusion, which improves blood flow to the heart muscle. And like other medications, nurses need to monitor for hypotension and peripheral edema in patients who take these drugs. Finally, we have statins, or statin drugs. These play a major role in our secondary prevention by lowering the cholesterol and reducing plaque buildup. So these are medications, there are, again, statin drugs. So simvastatin, atorvastatin, rosuvastatin, all of which decrease LDL levels and help stabilize any existing plaques, which reduces the risk of future heart attacks. However, patients do need to be educated on possible side effects of statins, like muscle pain, which could lead to things like rhabdomyolysis, or even liver dysfunction. They need to be taught the importance of routine lipid monitoring, as well as their liver labs. All right, so now let's talk about a couple of other ways that we can increase myocardial perfusion. And this is through reperfusion therapy. So this is a very critical intervention in the management of acute coronary syndrome. When a patient is experiencing an acute myocardial infarction, again, time is heart muscle. So the longer that the artery stays blocked, the more damage that actually occurs, which is why we need a rapid, effective strategy to restore blood flow to the heart. We have two main methods of reperfusion therapy. We have percutaneous coronary intervention, or PCI, which is the preferred approach whenever it's available. And we also have fibrinolytic therapy, or thrombolytic therapy, which is used whenever a PCI is not immediately accessible. So when we talk about fibrinolytic therapy, fibrinolytics work by dissolving the clot that is blocking the coronary artery, restoring blood flow to the affected myocardium. So this class of medications includes tissue plasminogen activator, also known as TPA. We also have tenecteplase and streptokinase. You may hear TPA also referred to as alteplase. So these drugs can be life-saving. Their effectiveness decreases as time passes. So that's why early administration is so important with fibrinolytic drugs. So the goal is to administer fibrinolytic therapy within 30 minutes of the patient's arrival at the emergency department. So now let's talk contraindications. Not every patient is going to be a candidate for a thrombolytic. There are some absolute contraindications, meaning that the therapy is simply too risky for these individuals. So some of our absolute contraindications would be a history of intracranial hemorrhage. We don't want to risk bleeding in the brain. Having an active bleed. Again, since this medication dissolves clots, it could cause massive hemorrhage. Another absolute contraindication is any significant head trauma or facial trauma within the past 3 months. Again, the risk of bleeding is just too high. There are also some relative contraindications where we need to really weigh the risk and the benefits. So these include things like uncontrolled hypertension, recent major surgery, pregnancy, active peptic ulcer disease, or the use of oral anticoagulants. The common theme here is that bleeding risk, which is why careful patient selection is so important. So say that we administer these medications for reperfusion. How do we know if it's working? So some of the key signs that the clot has been successfully dissolved and the blood flow has been restored is, first, the cessation of chest pain. So when the heart muscle gets enough oxygen again, the pain should subside. Another way to know that it's working is the sudden onset of ventricular dysrhythmias. So this might sound bad, but it actually indicates that the heart is responding to the restored blood flow. And lastly, we see the resolution of ST segment changes on the ECG. So the ST elevation should return to baseline. But, and this is a big but, we also need to monitor for re-occlusion of the artery, because thrombolytic therapy doesn't necessarily prevent the clot from forming again. This is why these patients will oftentimes be started on aspirin and IV heparin to help maintain the coronary artery patency. So let's talk about some nursing considerations for these fibrinolytic therapies. So if you do have a patient that's getting a fibrinolytic, we need to be extra vigilant. So before we administer the drug, we want to complete all invasive procedures. This means inserting IV lines, drawing labs, placing a Foley if that's needed, because once we give this medication, the risk of bleeding is extremely high. So we want to eliminate any cause of bleeding that we possibly can. During administration of the fibrinolytic, continuous monitoring is essential. So we want to keep a close eye on those vital signs, the heart rhythm, and the patient's neurologic status. A sudden change in the level of consciousness can indicate that the patient has a brain bleed, which is a very life-threatening emergency, on top of the one they're already having. All right, so now let's talk about our other reperfusion therapy, which is a percutaneous coronary intervention, or PCI. This is the go-to non-surgical procedure for opening or reopening that blocked coronary artery and restoring blood flow to the heart. So this intervention is literally life-saving for patients who are experiencing a STEMI. and it's the preferred method over thrombolytic therapy whenever possible. So what exactly is PCI? Well, a percutaneous coronary intervention is performed in the cardiac catheterization lab, where a catheter is inserted, usually through the radial or the femoral artery, and it's guided up to the coronary arteries. From there, it retrieves clots, opens up narrowed vessels via angioplasty, and places a stent to keep the artery open. The goal is to get this done within 90 minutes of a STEMI diagnosis. That's kind of the magic number. The faster the intervention, the better the patient's outcome. So let's talk about how this works. Breaking down the process. So a coronary angiography. This is where first the provider actually identifies the blocked artery using contrast dye and fluoroscopy. We also have clot retrieval. So if a clot is present, then a special device can be used to remove it. For a balloon angioplasty, this is where we can actually insert a small balloon that's going to be inflated once it's in the artery that's got the obstruction. And it's going to be inflated again to push plaque up against the artery wall, which widens the lumen of the blood vessel. And then we can have a stent placement. So a stent, either bare metal or drug-eluting, is deployed to maintain that arterial patency and to prevent future narrowing. And you can see that with the picture up there on the slide. So the top one shows where they insert the catheter with the stent on top of the balloon. B, you can see where they've inflated the balloon, pushing that plaque up into the walls of the vessel, and you can see the stent there. Then they'll actually decompress the balloon and pull out the catheter, leaving the stent in place to keep the artery open. So now let's talk about post-procedure monitoring once a patient's gone to cath lab. So just because the artery is open doesn't mean the job's done. After a PCI, nurses play a huge role in monitoring for complications, including acute closure of the vessel. So this can present as recurrent chest pain and ST segment elevation on ECG. So again, just because we think we fixed it doesn't mean that we did. Sometimes the vessel can still close, especially if we didn't put a stent in. We're also monitoring for bleeding at the insertion site. So if the sheath was inserted through the femoral artery, we're really going to be vigilant in watching for hematoma formation because we don't want this patient to bleed out. We're also going to be watching for any reaction to contrast dye. Patients can develop a reaction or even kidney issues, so we want to be sure to monitor their urine output and their renal function. We also want to monitor for hypotension and hypokalemia, both of which can occur post-procedure and may require IV fluids or electrolyte replacement. Also, we want to watch for different dysrhythmias. So reperfusion can sometimes trigger ventricular arrhythmias. So we want to keep that ECG on and be ready to intervene. As far as medications post-PCI, so to reduce the risk of reocclusion, patients will oftentimes require a dual antiplatelet therapy, typically aspirin and clopidogrel. Many will also be prescribed again beta blockers, ACE inhibitors, or an ARB to help protect the heart and prevent remodeling after the MI. All right, so now let's talk about dysrhythmias, which are a major complication in patients with acute coronary syndrome and one of the leading causes of death. So for our patients, early identification and intervention can make all the difference here. When a dysrhythmia develops, we need to take a systematic approach. First, we need to identify the dysrhythmia. So what are we actually seeing on the monitor? And next, we need to assess the patient's hemodynamic status, meaning how is their blood pressure? Are they perfusing well? And finally, we're going to evaluate for any discomfort. So we're going to see if the patient is symptomatic. Are they feeling lightheaded, short of breath, or are they having any chest pain? So now we'll kind of break this down by infarct location. So for an inferior acute coronary syndrome, dysrhythmias typically involve bradycardia or a second-degree AV block. And I know we're not going over AV blocks, but you will learn those in level 4. So these happen because the right coronary artery supplies blood to the SA and the AV nodes. So if ischemia affects these areas, then the heart's electrical impulses can slow down or just get blocked intermittently. These dysrhythmias tend to come and go, but if they start compromising perfusion, then the patient may need a temporary pacemaker. On the other hand, an anterior acute coronary syndrome is more likely to cause premature ventricular contractions, or PVCs, and this is due to that ventricular irritability from the ischemia in the left anterior descending artery. But the more serious concern here is a third-degree heart block or a bundle branch block. So these are rhythm disturbances that tell us that a large portion of the heart ventricle is involved. That's a red flag for poor cardiac output and potential heart failure. So in these cases, the healthcare provider may want to insert a pacemaker to help maintain that cardiac function. All right, so heart failure is a very common and serious complication that follows a myocardial infarction. When the heart muscle is damaged, particularly that left ventricle, it struggles to pump blood effectively, which leads to fluid accumulation and congestion. So this can result in symptoms like shortness of breath, fatigue, and edema. As nurses, it's important to assess those early indications of heart failure. So this includes listening to lung sounds for crackles, checking for signs of fluid overload, and monitoring for tachypnea or a frothy sputum, which can indicate pulmonary edema. Also, we want to pay attention to heart sounds. An S3 heart sound may suggest worsening left ventricular function. So let's talk about our management strategy. So the treatment of heart failure after an acute coronary event depends on the location and the extent of the cardiac damage. A key aspect of managing these patients is hemodynamic monitoring. So this provides data about their vascular capacity, their blood volume, their pump effectiveness, and their overall tissue perfusion. Drug therapy for this, so to improve cardiac output and to reduce the workload on the heart, there are several medications that may be used. Nitrates, which again dilate blood vessels to reduce the preload and the afterload. Inotropes, like dobutamine, which can enhance contractility and helps to improve cardiac output in cases of severe heart failure. Morphine, which not only helps with pain, but it also reduces pulmonary congestion by lowering the preload. And oxygen therapy can be used to optimize oxygen delivery to tissues whenever hypoxia is present. For those critically ill patients, we may have invasive hemodynamic monitoring used, and this is just to obtain very precise measurements of cardiac pressures and their fluid status. So this involves putting catheters into the heart and into the great vessels, and these require very specialized critical care settings like an ICU. All right, so now let's get into our care coordination and transition management. So when we think about treating acute coronary syndrome, usually our focus is on that acute phase, the medications, the interventions, and that immediate stabilization. But what happens when the patient leaves the hospital? That's where our effective discharge planning and care coordination really come into play. So as far as home care management goes, patients who are recovering from an MI, unstable angina, or a cardiac procedure like a PCI or a CABG, otherwise known as a cardiac coronary artery bypass graft, these patients should not be discharged home alone. They're still in recovery and they require ongoing care. They may need assistance with daily activities, medication management, and lifestyle modifications. A lot of patients will benefit from cardiac rehab, which plays a pretty big role in improving long-term outcomes. They promote exercise, stress management, and education on heart-healthy living. Next, we have self-management education. So patient education is one of the most critical components of care transition. Our goal is to empower our patients with knowledge and tools that they need so that they can maintain their health and prevent any future cardiac events. So with this, first is risk factor modification. So patients need to address their modifiable risk factors like smoking, high blood pressure, diabetes, and high cholesterol. We want to encourage that heart-healthy eating, physical activity, and adherence to their prescribed medications. Next, we have complementary and integrative health. So in addition to our traditional medical treatments, some patients can find relief through muscle relaxation, music therapy, pet therapy, and dietary supplements like omega-3 fatty acids and B vitamin complexes. Next, we have sexual activity. So this is a topic that often gets overlooked, but it's very important. A lot of patients worry about when they can resume sexual activity after a cardiac event. And a simple rule of thumb is if they can climb 2 flights of stairs without having any chest pain or shortness of breath, then they're typically safe to engage in sexual activity. However, we always want to advise them to discuss this with their provider. Next, we want to talk about drug therapy. So again, medication adherence is non-negotiable. Patients need to understand the importance of hyperglycemia control, how to properly take their cardiac medications to prevent heart attacks in the future, the need for vaccinations like flu and pneumonia vaccines to prevent infections that can exacerbate heart disease. We also want to teach them about nitroglycerin. So patients should carry their nitroglycerin with them at all times, and they need to know how to use it correctly during episodes of chest pain. One thing about nitroglycerin, usually it's going to come in that little bottle. You want to keep this in the bottle because it needs to be stored away from light and in a cool, dry place. One thing you want to teach patients is if they can, granted if they're having chest pain, it doesn't matter, but they have a family member or someone else handling the medications, we don't want to touch nitroglycerin with our bare hands because it can actually be absorbed through the skin. So anybody that doesn't need nitroglycerin doesn't need to be handling the medication. Also, again, with nitroglycerin teaching, they need to take this medication at the first onset of chest pain, and if their chest pain is still ongoing after that first dose, then they need to contact 911. So that kind of brings me to my next point, which is seeking medical assistance. So it's important that patients know when to seek immediate medical help. So again, they need to contact their provider if they experience persistent shortness of breath. Again, that chest pain that doesn't go away with nitroglycerin, a weight gain of 3 pounds in a week, which could indicate that they've got some fluid retention and worsening heart failure. And most importantly, again, like I just said, if the chest pain is not relieved after taking nitroglycerin, they need to call 911 immediately because, again, time is heart muscle. And lastly, healthcare resources. So we want to remind patients that they're not alone in this journey. Organizations like the American Heart Association offers excellent resources, education, and support groups for cardiac patients and their families. All right, so wrapping up our discussion here on acute coronary syndrome, we're going to look at evaluation and the expected patient outcomes. As nurses, our role doesn't end with intervention. We need to ensure that our actions actually lead to positive patient outcomes. So how do we evaluate whether our interventions have been successful? We have 3 key indicators here. First and foremost, the pain is alleviated. So one of the most immediate and crucial goals is that pain relief. Remember, myocardial ischemia leads to chest discomfort, and pain is a sign that the heart muscle is struggling for oxygen. If a patient reports reduced or resolved chest pain, that's a good sign that our perfusion is improving. Second, we need adequate myocardial perfusion. This is critical. So we assess perfusion through our vital signs, especially the blood pressure and the heart rate, ECG changes, which is where we're going to ensure that there's no ST segment elevations or depressions, looking at the troponin levels, which again should peak and then decline as myocardial damage stabilized. And then we're also going to evaluate the urine output, as well as skin color and cap refill, all of which indicate whether overall circulation is improving. Next, we want to make sure that our patient is free of complications. So our goal is to prevent complications like dysrhythmias and heart failure. So again, dysrhythmias, especially ventricular arrhythmias or AV blocks, can be life-threatening. Heart failure can develop from extensive myocardial damage, so we want to be vigilant in monitoring for crackles in the lungs, edema, and shortness of breath. So just some final thoughts here. We want our patients stable, comfortable, and free from any life-threatening complications. As nurses, it is our responsibility to continuously assess, intervene, and evaluate, asking ourselves, did our interventions work? Did we prevent deterioration? And are we keeping our patients out of the ICU or readmission? Every intervention matters. By focusing on these key outcomes, we can ensure that our patients recover safely and effectively. All right, guys, good job today. Keep all of these evaluation points in mind as you care for cardiac patients, and I will see you in class.